care insurance and one's personal finances pay for end-of-life care. Sometimes death is sudden, other times it is expected. End-of-life care may involve days, weeks, or months. Doctors cannot predict the exact time a patient will die. A terminal illness is an illness or injury from which the person will likely not recover. The two types of care for the terminally ill are hospice care and palliative care. With hospice care, it's a healthcare agency or program that promotes comfort and quality of life for the dying person and his or her family. Palliative care is specialized medical care for people living with serious illnesses, such as cancer and heart failure. Patients in palliative care may receive medical care for their symptoms, along with treatment intended to cure their serious illness. Patients in hospice care do not receive any sort of treatment for their illness. Palliative care can occur at any stage of the illness. It can be used in conjunction with curative measures. You do not have to be dying to qualify for palliative care. A doctor or advanced practice provider must certify that a patient has 6 months or less to live for a patient to qualify for hospice care. This graphic shows the differences and similarities between palliative care and hospice care. With palliative care, you can receive it at any stage of a disease, and it can occur at the same time as curative treatment. Hospice care, the prognosis of the patient must be 6 months or less, and patients cannot be utilizing curative treatments. The things that both palliative care and hospice care have in common are that they optimize comfort, reduce stress, provide emotional and spiritual support, and relieve symptoms. Some examples of palliative care. So if a patient is diagnosed with cancer, palliative care can consist of chemotherapy, radiation, medications to reduce the side effects of treatment. With cancer, palliative care doctors work closely with the oncologist. Cancer symptoms may include pain, nausea, vomiting, fatigue, and anxiety. The palliative team specializes in relieving these symptoms. The team can also help the patient interpret complex medical information. CHF stands for congestive heart failure, and palliative care would focus on symptom relief and mental health services. With CHF, palliative care would include medications to manage the symptoms, lymphatic drainage, which is used to reduce swelling in the lower extremities, and education on how to position oneself to improve breathing. With dementia, palliative care focuses on treating anxiety caused by the dementia. Palliative care can assist with helping families find a long-term care facility as the patient's dementia progresses. COPD stands for chronic obstructive pulmonary disease, and palliative care for COPD focuses on treatment for anxiety or insomnia. Palliative care works with the pulmonologist. They help the patient navigate the health system. They help the patient manage their shortness of breath with medications. They can also treat anxiety, depression, and insomnia. Palliative care specialists treat the symptoms and stress of illness. They work in conjunction with the primary medical team. Attitudes about death are influenced by experience, culture, age, and spiritual needs. Practices and attitudes about death differ among cultures. In some cultures, dying people are cared for at home by the family. Adults may fear pain and suffering, dying alone, and the invasion of privacy. They may also fear loneliness and separation from loved ones. Worries about the care and support of those left behind are common. Adults often resent death because it affects plans, hopes, dreams, and ambitions. Spiritual needs relate to the human spirit and to religion and religious beliefs. They involve finding meaning in one's life. Attitudes about death are closely related to religion. Some religions believe in reincarnation. Reincarnation is the belief that the spirit, after biological death, begins a new life in a new body that may be human, animal, or spiritual, depending on the moral quality of the previous life's actions. It is important for healthcare providers to have an understanding of their own personal beliefs about death. This will allow them to discuss the dying person's fears and concerns. It also helps the healthcare provider make sense of and cope with a patient's passing. It's also important to remember that each person is unique. A person may not follow all of the beliefs and practices of his or her culture or religion. The CNA should always follow the care plan. The stages of dying are also called the stages of grief, and they were described by psychiatrist Elizabeth Kubler-Ross. The stages are denial, anger, bargaining, depression, and acceptance. The first stage in the Kubler-Ross cycle is denial. This stage can last for a few hours, days, or much longer. Some people remain in denial. When in this stage, the person refuses to believe that he or she is dying. Information about the illness or injury is not heard, and the person cannot deal with any problem or decision about the matter. The next stage is anger. The person thinks, why me? There is anger and rage. Dying persons envy and resent those with life and health. Family, friends, and the health team are often targets of the anger. It can be hard to deal with the person during this stage. However, anger is normal and healthy. The next stage is bargaining. During this stage, promises are made in exchange for more time. The person may bargain with God or a higher power for more time. This stage is usually private and spiritual. The next stage is depression. During this stage, the person mourns lost things and the future loss of life. The person may cry or say very little. Sometimes the person will talk about the people and things that will be left behind. Finally, the last stage is acceptance. During this stage, the person is calm, at peace, and accepts death. Unfinished business is complete. This stage may last for many months or years. Reaching this stage does not mean that death is near. This is an infographic that shows the Kubler-Ross grief cycle. So when in denial, you will see the patient display avoidance, confusion, elation, shock, and fear. When a patient is in the anger stage, they will have frustration, irritation, and anxiety. When in the depression stage, they may feel overwhelmed, helpless, hostile, and want to go away from the situation or flight. When in the bargaining stage, the person may struggle to find meaning. They may reach out to others and they may tell one story. And finally, in the acceptance phase, individuals will explore options. They'll have a new plan in place and they'll be ready to move on. End-of-life care comfort needs. Comfort goals are to prevent or relieve suffering to the greatest extent possible and respect and follow end-of-life wishes. Listening and touch are important in meeting end-of-life comfort goals. With listening, the person may need to talk and share worries and concerns. It's important to let the person express feelings and emotions. The CNA does not need to say anything. Being present is what counts. Touch shows care and concern when words cannot. Sometimes the person does not want to talk, but needs someone nearby. Silence, along with touch, is a powerful and meaningful way to communicate. It is important to meet the psychosocial and spiritual needs of the patient and the family. Do not isolate or avoid the dying resident. Provide the opportunity for the dying resident to talk. Be non-judgmental about the resident and anything he or she tells you. Allow the resident to express his or her views on death and dying. Respect the resident's wishes for visits from spiritual leaders. Provide privacy for the resident and family and friends. Maintain confidentiality regarding anything the resident and/or family shares. Provide care with compassion, understanding, patience, and empathy. Care for the family of the dying patient. Communicate what is happening to the resident. Provide space for family members to be by themselves. Provide time for family members to be with the resident. Permit family members to care for the dying resident if they desire. Allow family members to verbalize feelings in a non-judgmental environment. Permit family to follow religious rituals of their choice. And do not be afraid to show your own emotion. End-of-life care. Physical needs, pain. At end of life, pain can range from 0 to severe. Some signs of pain are restlessness, agitation, frowning, grimacing, sighing, moaning, whimpering, crying, tense muscles, and tachycardia, or elevated heart rate. Some ways the CNA can help alleviate pain are to provide skincare, to provide personal and oral hygiene, back massages, making sure the patient has good body alignment, and frequent position changes. End-of-life care, physical needs, vision, hearing, and speech. As someone is dying, their vision blurs and gradually fails. A darkened room may frighten the person. The eyes may be half open. Secretions may collect in the eye corners. Use a warm, wet washcloth to gently clean the patient's eyes. Because of failing vision, the CNA should explain who they are and what they are going to do to the person in the room. The room should be lit to the person's needs. Avoid bright lights and glares. Good eye care is needed. If eyes stay open, the nurse may apply a protective ointment. Hearing is one of the last functions lost. Many people hear until the moment of death. Even unconscious people may hear. Always assume the person can hear. Give reassurance and explain care. Offer words and comfort. Avoid upsetting topics. Do not talk about the person. As death nears, speech becomes harder. It may be hard to understand the person. Sometimes the person cannot speak. It's important for the CNA to anticipate the patient's needs and ask yes or no questions. End-of-life care, physical needs for the mouth, nose, and skin. Oral hygiene promotes comfort. Give routine mouth care if the person can eat and drink. Give frequent oral hygiene every 2 hours as death nears and when taking oral fluids is difficult. A lip balm may be used for dry lips. Oral swabs, like the one in the video, can be used to provide mouth care at the end of life and when a patient is unconscious. You'll follow the care plan to determine if the swab should be dipped in water or dipped in mouthwash, as shown in the video. Crusting and irritation of the nostrils can occur as end of life nears. Nasal secretions, a nasal cannula, and an NG tube can cause irritation. The CNA should carefully clean the nose and apply lubricant as directed by the nurse. As death nears, circulation fails and the body temperature changes. The skin becomes cool, pale, and blotchy. Sweating increases. Skin care, bathing, and preventing pressure injuries is necessary. Linens and gowns are changed as needed. Even though the skin will feel cool, only light bed coverings are needed. Blankets may cause warmth and restlessness. End-of-life care, nutrition. Nausea, vomiting, and loss of appetite are common at end of life. The patient will be offered frequent small meals. The CNA should not force the person to eat or drink. End-of-life care, physical needs, elimination. Urinary and fecal incontinence may occur. Constipation and urinary retention are common. It is important to keep the skin clean and dry and change soiled linens immediately. End-of-life care, the person's room. The person's room should have good ventilation. Unnecessary equipment should be removed. Mementos, pictures, flowers, cards, and religious items may provide comfort. Legal issues. An advance directive is a document stating a person's wishes about healthcare when a person cannot make his or her own decisions. The Patient Self-Determination Act and OBRA give persons the right to accept or refuse treatment. Agencies must inform all persons of the right to an advance directive on admission. Living wills discuss measures to support or maintain life when death is likely. A living will address tube feedings, ventilators, and resuscitation. Durable power of attorney for healthcare gives the power to make healthcare decisions to another person. The person is often called a healthcare proxy. This does not cover property or financial matters. Finally, DNR stands for Do Not Resuscitate. It means that the person will not be resuscitated. The person is allowed to die with peace and dignity. This graphic shows the differences and similarities between an advance directive and a living will. An advance directive is more comprehensive, while a living will is specific to end-of-life care. An advance directive includes appointment of a healthcare agent. It guides medical decisions or appoints someone to make decisions on behalf of the individual, and guides medical decisions or appoints someone to make decisions on behalf of the individual. A living will specifies types of medical treatments desired in case of terminal illness or permanent unconsciousness. It guides medical decisions related to end-of-life care. It contains instructions regarding the use of medical interventions such as dialysis, machines, feeding tubes, and CPR. Advance directives and living wills are similar because they only apply to healthcare decisions. Regulations may differ from state to state, and consultation with a healthcare provider or a lawyer is recommended for both of them. Signs of death weeks or days before. The patient may experience restlessness, agitation, shortness of breath, depression, anxiety, drowsiness, confusion, constipation, incontinence, nausea, loss of appetite, healing problems, and/or edema or swelling. When death is nearing, movement, muscle tone, and sensation are lost. This usually starts in the feet and legs. Mouth muscles relax, the jaw drops, the mouth may stay open. The facial expression is often peaceful. When death is nearing, GI functions slow down. The patient may have abdominal distension, fecal incontinence, nausea, and vomiting. The body temperature changes. The patient feels cool or cold, looks pale, and perspires or sweats heavily. Circulation fails. The pulse is fast or slow, weak, and irregular. Blood pressure starts to fall. The respiratory system fails. Slow or rapid and shallow respirations are observed. Mucus collects in the airway. Breathing sounds are noisy and gurgling, which is known as the death rattle. Finally, pain decreases, and the person may lose consciousness. Some people are conscious until the moment of death. Signs that death has occurred. The patient will have no pulse, no respirations, and no blood pressure. Death is determined by a doctor. If a doctor is not present at a nursing center, a nurse calls the doctor to report the signs of death. The time and place are noted for the death certificate. Postmortem care is care of the body after death. It begins when the person is pronounced dead. It is done to maintain a good appearance of the body. It involves bathing soiled areas and positioning the body in good alignment. When moving the body, air in the lungs, stomach, and intestines can be expelled, which produces sound that is normal and expected. Rigor mortis is the stiffness and rigidity of the skeletal muscles that occurs after death. It occurs within 2 to 4 hours after death. The body is positioned in normal alignment before rigor mortis sets in. The body should appear in a comfortable and natural position when the family sees it. An autopsy is the examination of the body after death. It's done to determine the cause of death. Postmortem care is not done because it could destroy or remove evidence.